Okay, hello. Thanks ever so much for joining us. For anyone who doesn't know me, my name is Jessica Bomford. I work in the communications team at the Haemophilia Society. And this afternoon, we're going to start with a discussion about the 10 principles of care for women and girls with bleeding disorders. And I'm really delighted to be joined today by Dr. Keith Gomez, who's consultant haematologist at the Royal Free Hospital in London, and Gemma Gardner. Now, Gemma has a mild form of haemophilia A, and Gemma's going to talk to us on a personal level about her experience of care for both yourself and your family, I think, but you can tell us a bit more about that later. We will be taking questions. You can ask them at any point, but we will, unless it's really urgent, we'll probably take them all at the end. And if you're watching online, please do put them in the chats, and we'll make sure they're read out. So I'm going to hand over to Dr. Keith Gomez.
Well, thank you very much, Jessica, and obviously to the Haemophilia Society for inviting me to come and talk to you today. I know it's a challenge when you have virtual and live meetings together. I've had to do one of those, and it's pretty hard, but well done, anyway, for organising that. Okay, so so this is what I'm going to talk about. A manuscript, really, that we produced, published maybe a couple of months ago, and I'm going to take you through that. But by way of background, I thought I'd start off by explaining why we needed this paper. So here's some data from the National Haemophilia Database. And what I've done here is just taken an extract of the numbers from the database and showing you the disorders, and obviously split into males and females. And as you'd expect, the haemophilia, of course, you've got more males than you have females. But the more common bleeding disorders like von Willebrand's disease, clearly more females, even though it's an autosomal disease. And when you look at the final numbers here, you've got slightly more females than you have males in the whole registry, but the important thing about this slide really is to recognise the very marked discrepancy in gender between the X-linked disorders here and the milder or autosomal bleeding disorders. Okay, and I think that's important when we come to think about some of the problems that we'll discuss later and why there are differences between how haemophilia is managed and how these other disorders are managed. So one of the big problems here is that while it's really quite easy to diagnose haemophilia, or certainly severe haemophilia, it's quite clear that we are missing ladies and girls, women and girls with bleeding disorders. And here's some evidence for that. So we know, because we understand genetics completely well, we've known about that for years, and most bleeding disorders, we know exactly how they're inherited. So we know how genes are transmitted, and therefore we can easily calculate exactly how many people there should be with a disorder in the population. And so we know that for every male, there should be roughly 1.5 carriers. Okay? And the slide I showed you previously captures all the carriers with low levels, and about a third of carriers have low levels. So if you then do some simple maths, you see this is the same row I showed you before. That's how many females there are in the database, and that's how many there should be. So we're missing in the UK about a fifth of carriers with low levels. Okay. Now, that's not great, but it's a lot better than the rest of the world. So, a third maybe of ladies missing the diagnosis. And this is even though many of these women will come from families where we already know that there are men in that family with haemophilia, and despite that, we're still not diagnosing them. So there's clearly a problem here, and we need to think, why is it that we're not making these diagnoses? Why are we missing them? And here are some of the reasons. So I already mentioned that milder bleeding disorders are a bit harder to spot because it's very easy to make a diagnosis of severe haemophilia because you've got a really low factor level. There's no question of it being of a normal result. Whereas if you've got a slightly reduced factor level or a condition like von Willebrand's disease where the assays are not that easy to do, then you might not see it quite so easily. And while we might not easily be able to do something about that, these other problems down here we certainly can do. And there's no doubt that a big issue is lack of awareness amongst the ladies and girls who have these conditions, but also about healthcare amongst healthcare professionals, because most women and girls with bleeding disorders, they don't necessarily present to haematologists who know about these conditions. They present to GPs or other specialties. And I'm not suggesting that they need to think about haemophilia straight away, because quite clearly when someone's bleeding, there's a myriad of causes that could be the explanation and not necessarily a bleeding disorder. But there does need to be awareness. And I think this is some upsetting stuff here. Sexism in medical practice. This is the 1820 was the first description in the medical literature of the genetic basis of haemophilia. And I think this is quite a telling statement which appeared in that paper. Haemophilia is transmitted entirely by unaffected males to their sons. No mention of the fact that those sons then transmit it onto their daughters. Don't worry about them. And you notice that this is an American spelling, so you might go, oh, well, it's fine, it's the Americans think these things, not us. But here we go, 1886. This appeared in The Lancet in the UK, one of our premier medical journals. Females hand down the disease, while the males are the victims of it. Okay, admittedly, we're talking 1.5 centuries ago here, okay? So hopefully things have moved on a bit, but it gives you an idea of why there's some problems. And this is to do with haemophilia, which clearly there's going to be a focus on males certainly many years ago, and that makes sense. But I think what's more telling is this data on von Willebrand disease, which is obviously not an X-linked disorder. Autosomal must affect men and women equally. So here's some data from a global study looking at when males are diagnosed. 3/4 of males diagnosed by the age of 10 years, and yet half of females not diagnosed by 2 years later. There's no real explanation for that whatsoever. You can't justify that, because this is before puberty. There's no way there's going to be any difference in the symptoms here. There's just got to be some problem with how women and, well, girls in this case, are not being recognised or not being adequately given the opportunities to be diagnosed. And look at this absolutely shocking number here. Globally, again, on average, women experience a 16-year delay between the start of their bleeding symptoms and actually being worked out that they have von Willebrand's disease, which I think is, well, that's clearly not good. And so we need to do something about that. And this is where we started here. So the European Association for Haemophilia and Allied Disorders and the European Haemophilia Consortium got together a few years ago, or rather put together this multidisciplinary working group a few years ago to try and tackle these issues. And here you can see the composition of the group. And I was lucky enough to be one of these haematologists in the group. And you can see we've got a lot of different areas of expertise here, including patient. And I must say, when I joined this group, I had a bit of trepidation, because I walked in, I realised that I was the only person with a Y chromosome. I thought, oh my God, this is going to be a bit hard. But I have to say that, all the ladies were really nice to me. And despite my obvious disadvantages here in understanding this subject, there was no discrimination whatsoever. So you see, it can work. And so what we did was we had a series of meetings. During the pandemic, it obviously became virtual. And then we created these principles of care. And then we surveyed members to see what they thought of them and whether they made sense, both with patients and with healthcare professionals. And then with a bit of adjustment, we've then this year presented them at the annual meeting of EAHAD earlier this year and had a webinar, and it's about dissemination now. So what I'm going to do now is just go through these 10 principles of care. So the first one, equitable access, all about equitable access. So I've shown you clear data that there is not equitable access. That's the only real explanation for some of the differences I've shown you on the previous slides. How do we do that? Well, we need to ensure then that there's And you know, I'm not saying that we need to remove services from males, of course, or other, you know, or detract from the services that we currently have. But we have to be aware of more female-specific bleeding symptoms and deal with those in an appropriate way. So that's the first principle, equitable access and quality of care. So that then should lead to a much more timely and accurate diagnosis, because obviously getting it right and understanding what's wrong with someone is how we're going to help their management. And as I said, that needs education of public and also healthcare professionals and you know, meetings like this where we're discussing these issues to then work out how we refer patients. Because you know, it may be that it's not easy for GPs or gynecologists who are outside of specialist centres to know how to access these referral pathways. And then we need to think about systematically identifying who may have a disease in a family. And then obviously looking after them in haemophilia centres. And of course it changes over time. So here you've got 3 stages of a woman or a girl's life. And the help that might be needed or the symptoms they might have will of course vary from the start and as someone gets later on. And if we understand that, we then manage it better. And it's not just about doctors and nurses and other allied healthcare professionals managing it. It's about women being able to manage it themselves, and it's not all about medicines necessarily. It may be other things that are needed to help with sorting out whatever symptoms they have. And, you know, as I showed you, 16 years in delay of diagnosis. Now, during that time, some of those women would have had procedures, operations, even hysterectomy, without knowing that actually what they had was von Willebrand's, and they could have had something else done to stop them maybe needing those operations. And that's definitely been a feature even in some of the patients I've seen in my clinic. So when we think about how we're going to find cases or work out, then we need to perhaps move focus, or obviously focus on, say, a boy or a man with haemophilia, but think about the other members of his family, his sister, his mother, his aunt, so that we can work out who might also be affected and who might also need some help. And so having a more family-centered approach. And as we move, as that boy grows up and becomes an adult and moves into a different phase of his life, then it becomes his daughter or his nieces that also become important. So it's something that, rather than sort of keeping a snapshot when we first see someone, it's something we have to revisit during someone's, during the times they're reviewed, basically. And when it comes to specific issues, so female-specific issues, obviously pregnancy, then we know that as haematologists, then we can't, we're not the ones who are going to be actively involved in managing that. We need help. And the best way of doing that, clearly, is providing that assistance or providing that management together with the obstetrician. And I'm really lucky that at the Royal Free, we have an obstetrician and gynecologist who's very, very dedicated in this area. And we have a joint clinic. And that seems to me perfectly obvious. That is what you should do. You should have a joint clinic so you don't have a situation where someone sees the haematologist one day and then goes and sees the obstetrician next week or next month and gets told something slightly different. That's not going to help. But that's not quite as easy as it might seem to set up, because these are different departments, they have different priorities. So in some hospitals it's not so easy, but if you do get it right, then you get a much more individualized and patient-centered approach. And it is also about empowering, I think, people to know when they should be seeking help. So understanding what's normal and what's acceptable, and when to think, hang on a minute, this isn't quite right, and I could do something about this. I don't have to just put up with it if you like. And we need to be aware that that's something which has to be done appropriately for that person's age. I have a 19-year-old daughter. There's no way she'd want to come and talk to me about anything like this. I'm not even sure she talks to my wife a great deal. But it is about understanding that there are these barriers, and who would she listen to? Maybe she listens to her friends. I don't know. And then, it's about being able to help and providing people with the strategies to help themselves as well. So clearly one of the big issues then, and one of the reasons why there are problems that are not recognised is treatment of heavy menstrual bleeding. Recognising when there's an issue and managing it appropriately. Being aware of when the problems can arise, whether it be at the beginning or towards the end, and then understanding it, because it's what is normal, what's abnormal, what should we consider to be standards, and we need tools, and those tools are there. So things like a pictorial bleeding assessment chart, and then clear referral pathways for dealing with these sorts of problems once they get brought to attention. So pictorial bleeding charts are something that we use. You can get them from your Haemophilia Centre, or you can just go and type into Google, Pictorial Bleeding Assessment Chart. And if you do, something like this will come up. And you can see it's a really simple way of measuring how much someone's bleeding. And it's just basically a simple thing where you put marks on here to show how much protection is being used, and then you get a score at the end. And the higher that score, the more bleeding there is. So how does that actually work in terms of symptoms? So PBAC, this is using the chart that you had on the previous page. So taking people who've got a score above 100, so heavier bleeding, against those who have a lower score. And so these black bars are perhaps appropriately those who bleed more, and then the kind of paler, spotty ones are where there's less bleeding. And you can see that in all of these 5 categories, apart from sports, which surprised me a bit, in every other category, the ladies or the women and girls who bleed more, the black bar, is much higher than the spotty white or pale bar. And looking at absenteeism here, 2.5 times maybe more likely to miss school, miss work because of heavy menstrual bleeding, and then all the fun stuff, social activities, sleepovers, if indeed they are fun, and travel. Then, these are things that people may be missing out on. So, these are simple tools that we can use, and someone can kind of do a chart and go and show it to someone, and then go, look, there's something not quite right here. This is actually my own specific area of interest, because I run the genetics lab at our place, and it's about, to me, one of the big areas is for people to be aware of their reproductive choices. And what I mean by that is deciding whether or not in some cases it might even mean whether someone has a choice about transmitting that disease, which may sound, gosh, I've got a choice. I didn't even know I might have a choice. But it's about thinking about this sort of stuff earlier. And because the problem is often we think, or I get referred people when they're already pregnant, and of course we can't think about it, that some of that choice is gone then. That doesn't mean there aren't still choices, there are. But the earlier this gets thought about, the better it is, because some of this stuff takes time, and making a genetic diagnosis, for example, is relatively simple now in the UK. In fact, it's pretty much universally accessible, but it still takes time. It might take a few months, for example, so it's something to be thought about. And then coming towards the end now, the last couple of principles that are that coming back towards pregnancy again, and actually delivery, being at the sharp end. How do we manage that? And again, we've got to have appropriate ways of understanding not just the risks to that mother, what they are. There may not be any, or there may be some, but there needs to be awareness of that, and also obviously the fact that there'll be a child at the end of it who may or may not also have some risks, how we're going to manage that. And also the effects of pregnancy, because pregnancy affects both the bleeding risk in its own right and also the clotting risk, and we have to manage those appropriately. And that requires some care and attention. And then finally, we know that for haemophilia, we're in a fantastically good place, as you'll hear from Pratima in the next talk, because over the last few years, there's been vast amounts of excellent research that has led to new treatments, new products, and that's massively changed the outlook for many patients with haemophilia, many men and boys with haemophilia. But as we go forward, we need to make sure that we think about our women and girls as well who are involved with bleeding disorders, so that rather than focusing on what may be more male-specific symptoms, we include female measures of bleeding in these studies and in these databases, and involve the women and girls in these studies so that we understand their symptoms as well and how we can adapt treatments to help them. That's my last slide, so I'm going to hand over to Gemma, who's going to tell us about her side of things.
Right, hi everyone, can you hear me? So when Deborah asked me if I wanted to come and talk today about the principles of care and women with bleeding disorders, I must admit I got a little anxious. I've spent the last 10 years standing in front of people and talking about having a son with haemophilia A, how it was as a mum coping with the diagnosis, how it was with him growing up in our world, and the clinical trial he's been on in the last 8 years. So actually this is the first time I've stood up and spoken about our side of the story, I guess mine and my daughter's side of the story, which isn't all that exciting from my point of view, and not all that gruesome either. I haven't got any big things to tell you. But what I will tell you now will make you understand how important these principles of care that Keith has just explained to you, and how important they are to me, my daughter, and to women and girls all over the world, I guess. So the first thing I heard about bleed disorders was about 10 years ago, which is absolutely crazy, bearing in mind it's a genetic inherited disorder. And this is the same for many other women in this situation. So my son, at just under a year old, was diagnosed with severe haemophilia A. From about 6 months, he had large lumpy bruises. We went to the GPs. The first GP said, "It's fine as long as the bruises go away." I went away, trusting my GP. We travelled the world a little bit. Anything could have happened in those 2 months. And then my mum and my mother-in-law said to me, "You really need to go and get this checked out. It's not normal." And I knew it wasn't normal. I had a daughter who was 3 years old, and she was throwing herself around much more than my son. And he wasn't hurting himself or anything. He just had bruises in very strange places. So we went back to the GPs, and this time I made sure we saw a different GP. This GP took one look at Zane's bruise. He had one on his side, which was actually really faded at the time, and I thought it was in pretty good shape. He looked at the bruise and said, "I've never seen bruises like this on a child before." I was rushed into another room. Photos were taken. The hospital was called. And I overheard the GP explaining to the hospital, "No, don't worry, your son, this child is not being hurt at home. I know the parents, they're fine. I trust them, it's okay." That was terrible in itself, let alone the fact that now we knew that there was something wrong with Zane, but we didn't know what it was. Sorry, I keep on saying about Zane, that's my son's name, makes it easier. So I took my mum with me to the hospital, and we had blood tests. And then the consultant sat with us for a bit and was asking about any pre-existing conditions, any family history, anything about that they should need to know. And actually, I said, no, we're really healthy. My mum's Italian, we have a really healthy diet, everything's fine. And suddenly, out of nowhere, my mum turned to the consultant and said, my grandfather had haemophilia. And I looked at my mum. And then the consultant went to get a piece of paper and a pen out, still smiling at us in a pleasant way, and just showed us with the X's and the Y's and how it all worked and how actually potentially our son could have haemophilia. But my mum said, "No, it can't be that, because when my daughters were born, I asked the doctors and they said it's fine, girls don't get haemophilia, so you don't have to worry." So on that day, when my mum was told that information, that was the last that was discussed in our family. We never talked about haemophilia. I'd never heard of haemophilia or bleeding disorders. There was some talk of stuff about my great-grandfather dying when he was quite young. He lived in a very poor village in Italy. He was a farm labourer. So, life was tough in those days, but nothing about haemophilia. So, which seems crazy. Even my grandmother, I spoke to her this week about the fact that she was a carrier. I talked about something to her, and even she's still in denial. She doesn't really get it as much as I've tried to explain. There was so much stigma related to it all 100 years ago. Everyone said they shouldn't marry my grandmother because there was something funny in the family, and so I'm not surprised that on that day when my mum was told not to worry anymore, that we didn't look any further into it, and it was never talked about. of course, until that day. So then when my son was born, as with every other mother who has a child diagnosed with haemophilia knows, you spend the next few years just surviving and trying to get back to normal life. I can honestly tell you my son is 11 years old now. He is amazing, he is crazy, and he's very healthy, and he, apart from contact rugby, he does everything else, including skateboarding, snowboarding, very scary stuff, but he is definitely living his best life. So we've come a long way with him. So I started to reflect back on my life, and I thought, this is crazy. How did I not know I had a bleeding disorder? Apart from the obvious things. But as a child, I had a tooth removed, and I bled and bled for days. Mum and Dad took me to A&E. They all shoved my mouth full of gauze and cotton wool. I came home. I went back in again. The doctor said, I think it's just an infection. It'll be fine. And sure enough, 3 or 4 days later, I stopped bleeding eventually. Nothing too serious, nothing that warranted, anything in the hospital or anything. I bruised quite a lot, but then I was also seen as being quite clumsy as well and very accident prone, so that was just seen as normal. And within my family, if we all bruised a bit, I had no one to compare it to anyway. In my late teens, I had some minor surgery, and once again, bled and bled for days. And the same with the mouth thing, it's just in a funny area, it might bleed a bit more than normal. Well, it bled a lot, and no one did anything or questioned it. My parents didn't question it because they didn't think of that. My nan didn't think, this is similar to what her father went through. Nothing was questioned at all in those years. I had heavy periods, but then as a child, I didn't talk to my mum about my periods. I didn't talk to my friends about my periods. So I didn't know what a heavy period was. Still to this day, I don't know what a heavy period is. And I just assumed it was normal and women did that. I was permanently anemic all through my life. When I was pregnant, I was really anemic. And this was just something, the build-up of everything over my years that make me now stand here and say, how did I not know I had a bleeding disorder? But I actually really honestly didn't. And no one in the healthcare professional I saw did anything different or questioned or suggested that maybe this wasn't normal, that you were bleeding after having a tooth extracted and 4 days later. That wasn't normal. So that's where I was, so that's how that went. So now I also think back to, I was also very lucky when I was pregnant. I had very good pregnancies, very good labours, and no issues there. But I do look back and think, if something would have happened on giving birth to my children, due to the ignorance of not knowing about my bleeding disorder, how would I have felt today? When I'm speaking to you here, would I have been painting the same picture? And that's why these principles of care are so important for this. So through my lifestyle, all the times, the principles of care would have ensured that I hadn't been in those situations. I think the biggest thing is with GPs, A&E, we've come across them all, and even the GP didn't pick up my son's condition, let alone my condition. And the same with dentists and things like that. It's so important. So now going forward, I then reflect on my daughter's life. So she's 14 now. And so when my son was diagnosed, it was amazing. It wasn't amazing. Sorry, I didn't mean that. What I meant, it was amazing the care that my daughter then got, and I got that day. I fully know that we're at a very, very good centre. And so we're very lucky there. So as soon as he was diagnosed, I had my blood tested and my genetics tested. My daughter then straight away at 3 years old had her her blood tested. And instantly my daughter and I knew that we had lower levels of factor VIII, so factor VIII deficiency. So we were both issued with bleeding disorder cards, which was fantastic. So I knew that if she needed surgery, if she needed tooth removed, that she wouldn't have to suffer the same things that I suffered, and that we understood, and I've been very lucky through my life. I've not had to have serious surgery, but if she does, at least we're in the best place now that we know she will be safe because we know her factor levels are lower. And I think this is so important. She's 14 now, and recently we went into so she has appointments in the same place as my son does, and she gets to see the full team like my son does. So last time we all went, and she got her own private time with the consultant, with the nurses, with anyone she wanted, and she was able to talk about her menstrual cycle because she's just started to go through all that. Hopefully, that whole process, she now knows she can speak to people and get the care extra medication or anything she needs, and psychological help. She's grown up with her brother, so she understands and she's educated and empowered now to be able to look after herself through her lifestyle and then through her life cycle. And also when it comes to her having children, hopefully the transition to adults will be really good because of the principles of care to make sure she is then able to be well cared of if she wants to make decisions and choices with having a family, and also after that. And actually the adult area concerns me a little bit more so than ever, because since I've transitioned, since I found out about my having mild haemophilia, I don't think I've been into my adult centre, whereas we spend our whole time focusing on our paediatric centre. I do, however, know if I phone them, they would see me straight away. But I don't get an annual letter saying, do you want to come in and see us or chat about things? So, yeah. But I think the biggest thing is for women out there, the symptom check is brilliant that the Haemophilia Society have just launched. Because I know I speak to people every day who don't know anything about haemophilia or bleeding disorders, and I'm sure sometimes I will speak to someone who has more than a heavy period, and if they've just known a little bit more about it, they'd have been able to do something about it, and I think that is so, so important. I think I've probably missed some stuff, because I always talk about different stuff every time I talk, so if anyone has any questions. No, actually, can I add something quickly? Sorry, just while I was on the thought of that, what my husband and I discussed this week was quite interesting. We had discussed it if I hadn't have had a son and he'd have not been diagnosed with haemophilia, where I would be today, because actually my daughter doesn't really have any signs at the moment. And without thinking about the history, I mean, someone might have brought it up at some stage, so maybe it would have been good. Maybe one of my family members would have seen something about this and thought, actually, yeah, oh, that's funny. Maybe we should bring up the fact that my grandfather had haemophilia, and then it might have actually been talked about over the last years, and maybe that would have brought up like that. But it did make us think a little bit. Would she have been on the same track as me now, or would things have been different this time, because the awareness now is getting better all the time? So I think that's really important. Okay.
Okay, so Dr. Gomez and Gemma are just going to take a seat, and I will as well at the front, so we can be a little bit more informal for questions. Gemma mentioned the launch of the Haemophilia Society's symptom checker. If any of you follow us on social media, you've probably seen quite a lot of posts this week. In short, it's a survey which is aimed at women and girls who have heavy periods, and it takes them through their symptoms, and at the end offers guidance about what the next step should be. And we are hoping that is going to reach beyond our community, but is also very relevant, as Gemma's highlighted very clearly, within our community. We're hoping that's going to drive more diagnoses and get people to understand that they perhaps need to push beyond their GPs to get the specialist care that they need. So if you haven't seen that, please share it, please look for it. It's on our Talking Red section of the website. Share it widely with your network, and hopefully we'll get more women and girls involved in the Talking Red campaign. So we do need to finish at 2:15. So could I ask, does anybody have anything they would like to ask either Gemma or Keith?
Son was diagnosed and you were going to, well, before he was diagnosed and you went to the GP, was there any concern in your mind about social services and the bruises on him and how that might be perceived? I know it wasn't with the second GP you saw, but originally was that a concern in your mind about, seeking help?
It wasn't at the time, because I guess I was seeing the GP regularly about my son's eczema anyway, and so I went back to the same GP because I trusted her. So I hadn't really I didn't really think about that originally, because I knew he was fine. And when I went into the GP, I was so surprised that she was so concerned about his eczema but not concerned about his bruising. And actually, I'm also very surprised, now you're saying it, you realise stuff all the time, don't you, how crazy it was that day when I went with bruises, because he had bruises across his ribs, so a very unusual place for a 8-month-old baby to have bruises, why that doctor didn't actually suddenly get flagged, not the bleeding disorder thing, but flagged the fact that there might be an issue here and that's not right. So yeah.
Hello. Listening to your speech here, it's something that we both come from more or less the same background, the Mediterranean background, in which I can summarize what you said in 2 words. First is deniability, and second is stigma. So the families, for whatever reason, they use deniability in order to prevent any consequences of this disease, which was stigmatized for a long time. Now, with this in mind, and most likely this will continue to be the case, why is it not a common practice that a PTT test is done anytime the bleeding is longer than what it should be?
I'll take that one. Yeah, well, that certainly it should be. I don't deny that. But I think it's important to remember that, one of the reasons I showed you that very first slide is that when we think about bleeding disorders, 15% of bleeding disorders are haemophilia. 85% are not. So you would miss them if you did a PTTT. So what I'm saying is that actually, I think actually what we try and do now is get away from doctors relying on that test. Because I've seen plenty of cases where people relied on the test and missed von Willebrand's disease or missed severe bleeding disorders. So actually, I think the point really is how is it best to make the diagnosis? And while the APTT is an important tool for diagnosing haemophilia, the most important tool is listening and talking to someone, because then you get the symptoms and then you can do the test. So yes, we use the APTT and we should do it. It's an easy thing to do. I'm not denying that at all. Well, I think the problem is that what happens is it's not the start, it's the finish as well. And when it's the finish, then you miss everything. So you're right that we should use the APTT, certainly, and it's not a different... In fact, I've never known that to be, certainly in the UK, to be a problem, that people don't do the test. The problem is that people do it, it's normal, and they go, that's it, fine. We've excluded haemophilia, we don't need to worry about anything else. That's the problem as well.
Keith, it's me over here. Hello. It's really great that we're focusing on women today, but I wondered how you focused on the men in your bleeding disorder service, haemophilia or other, for when they have children. So how do you diagnose those obligate carriers, but also perhaps the type 1 von Willebrand's disease gentleman who has a little boy? How are you finding them? Because they're probably not telling you they're pregnant.
Yeah, I mean, you're absolutely right, and I think this comes from the same, following on from that previous question. Then it is about having those diagnostic strategies available, not just for haemophilia, but as you say, for von Willebrand's and other conditions. I think one thing I would say there is that it is about being aware of, as much as you can, about the symptoms so for example, in your case, in Gemma's case, with hindsight, there were some symptoms in the previous generation, or maybe the generation before that. And so clearly taking the family history there would help. But we mustn't forget that 50% of cases of haemophilia are sporadic. And so no matter how good a family history you take, if that's not going to help you there. So you've still got to have a way of diagnosing those individuals. And that's where it is about, I think, being very clear about or as clear as you can, is about what's normal and what's abnormal, such as when you have your tooth out, okay, fine, what you said, clearly most people would now think that's not right, you don't bleed that much, but it's about adding those things up, I think, and having those in our diagnostic armamentarium.
Thank you. We've got one question that's come in from online, and it says, how often, this is aimed at you, Keith, how often do you get referrals from GPs about people with about women with suspected bleeding disorders?
I'm happy to say that I now get more than we used to, which is great. So we've kind of increased the clinic for mild and moderate bleeding disorders, and that's predominantly females who get referred to that. And I would say a lot of them do come from GPs now, whereas perhaps when I first started 15 or so years ago, the vast majority of referrals came from another haematologist. Whereas now I think the GPs are becoming more aware of it, which is a good sign. Yeah.
Okay, is there anybody else, Clive? I think this is going to have to be our last one, actually.
I was going to ask, what role do you think education plays in misunderstanding women with bleeding disorders? And to that extent, I'm talking about general education and education of doctors, to the extent that most of us, when learning about bleeding disorders at school, it was probably in a biology class learning about genetics and how it's inherited, and we're very hardwired to think that boys get haemophilia and girls carry it. And equally, how is that reinforced to an extent through the way doctors are taught and trained, obviously other than haematologists, for example, and what can we do to potentially change that?
You're absolutely correct, and you heard that, you know, in Gemma's story, a clear point about that was that there was some misunderstanding at the time when it was your mum or whichever, you know, clear misunderstanding there, and you're absolutely correct. The only way through that is to educate as best we can at all levels, and schools. Well, that's not my area particularly. I guess you'd need to speak to teachers and so on, or we'd need to, but. You know, there's an awful lot of stuff to fit into curriculums. That's partly the problem, and it's about finding the correct time. Even in medical school now, haematology, in a 5 or 6 year medical degree, haematology takes up about a month, something like that. You know, and actually half of that, or not half of it, 3/4 is about things like leukemia, which I'm not trying to deny is not important, but you know, it is about space and it is about fitting it in. And I think all we can do is increase those opportunities. But I think probably we're not going to suddenly find space in those areas. But I think that an area where we definitely can improve is actually is improving education to the women who would have these conditions themselves. Because while that is, I think, tackling the more sporadic cases, what I think is really upsetting is when you hear that a lot of the women who are not diagnosed have people with haemophilia in their family. Now that to me is, I mean, you know, how can you? They know about it, but they didn't know it could affect them because they simply weren't, or they were given the wrong information. Actually, which is what happened in your mum's case. The fact that someone gave them the wrong, they asked the question sensibly, and they were told the wrong answer, and that sadly still happens sometimes.
Okay, well, thank you very, very much. That was really thought-provoking, and I know you have to rush off to something straight away, don't you? But hopefully people can catch up with Gemma and Keith at some point this afternoon. Okay, thank you very much.